Yes, so the topic of today is how to start or set up mechanical insufflation-exsufflation. We try to keep it in basics, how it is in the start. I'm really honored to be here with you, and I'm Yes, so I will have a following agenda. I will go through what to consider prior at the start, how to introduce this to patient, and how how to set up. A little bit about the evidence of the settings and also the user perspectives in the end. And I'm initially a clinician. We have been working with MI therapy here in Norway since 2001, when the MIE device was possible for us to use. And Bergen, it's in the west coast of Norway. So here it's 4 p.m. and I have been working the whole day already. This is a picture of our city, which is approximately 400,000 people living here in Bergen. So it's not big, but it's still the next biggest city in Norway. And so my presentation will be both experience-based, but also based on the evidence that is available, and also based on the user experiences we have. We have used this therapy more than 20 years clinically now. Um, yes, so what is the clinically successful use of the MIE? So we aim to improve the patient's ability to cough. We aim to clear the airway secretions and mucus plugs. We aim to treat and prevent pulmonary complications in people who have weak cough. And these kind of complications can be pneumonia or atelectasis. We try to prevent the need for tracheostomy in our ventilated patients, and we actually manage quite well the success with non-invasive ventilation when we are good to clear the secretions from the airways. If we have tracheostomized patients, we use this active in decannulation, and we see that we use less time to chest physiotherapy and airway clearance therapy when we are adding MIE to treatment in those patients who have weak cough. Indications are simply individuals who have airway secretions in the central airway, but who are not able to cough up by themselves because of weak cough. There are some precautions and contraindications. Initially, this treatment was aimed to be used in neuromuscular patients who basically have healthy lungs. They have weak muscles and might also have stiff thorax. But it has potential to shift an overwhelming amount of airway secretions, which need to be cleared when we start the treatment. Some patients with bulbar dysfunction might have limitations, but we will have focus next week in the next session about these cases. Also, non-invasive use, which is in my main focus today, requires patient cooperation for optimal benefits. There are some precautions and contraindications as well for MIE therapy. I have listed them here and I can send them in the summary. But it's mainly if patients have pulmonary issues, we should be careful. I mentioned that initially this was a treatment for patients with neuromuscular disorders, and in 2018, these clinical guidelines were published about different techniques that can be used to cough up secretions and mobilize the mucus in individuals with neuromuscular disorders. And in these guidelines, also MIE, mechanical insufflation-exsufflation, alone or together with manually assisted cough is mentioned. And it's mentioned and recommended most for the patients who are the weakest, who are less forced vital capacity left and has weakest cough peak flow. Compared to other techniques for airway clearance for this patient group, like glossopharyngeal breathing, air stacking, manually assisted cough, MIE therapy cost more, and it also needs more amount of assistance to use it. So it's cost more, but it's very good option for the weakest patients. And to find out if the MIE is the right treatment for these patients, or we should choose another airway clearance therapy, we perform an individual assessment of the patient, where we take some measurements like cough peak flow, vital capacity, and also maximal inspiratory and expiratory mouth pressures, MIP and MAP. We make an assessment of more qualitative assessment of cough, if it sounds effective or if it sounds very weak. Does the patient manage to perform a cough sound? If they manage to perform E phonation, because it can say something about the vocal fold movement in these patients, and also other pulbar functional evaluation, like how the patient speaks and phonates, and also swallows and eats. In long-term setting, which I have most experience from, we also make evaluation of what kind of resources patients have to master the home treatment. Is it like the old wife who is helping him, or is it parents of children, or is it home care providers or home nursing? Or if the patient have personal assistance. And we always perform therapeutical trials with different techniques. Often these cough peak flow values already guide us where to start, and we make an evaluation of effect, both for cough peak flow. Does the technique increase the vital capacity, and also make an evaluation together with the patient, how they think they master this technique in home setting. Is it a good choice? And these things can help us to decide the best airway clearance technique for the individual patient. And what is effective cough? Well, cough is a function. It's a combination of three different phases: an inspiratory phase that increase the volume, glottic closure and opening, and compressive phase, and further expiratory phase where we expel the secretions. And this function requires coordination of all respiratory muscles, both inspiratory, expiratory, and laryngeal muscles. They need to be timed in right time, and you need to generate right power or force. And this video will show how the cough, it's a spontaneous cough, in slow motion. That looks like in the upper airways in larynx. It was an initial opening, then it was a closure. And you also see several closures and openings, which are quite useful to perform during the expiration phase. It can be measured with a very simple measurement of deep inspiration combined with cough, the PEF meter, that gives us a cough peak flow value. In this patient with spinal muscular atrophy type 2, it was 180 liters per minute. And this value can help us to define if the cough is effective, or is it weak, very weak, or not functional anymore. And his value of 180 liters per minute tells us that it's very weak. The risk for pulmonary complications is moderate, and we should start preventive cough support, but it's also very close to 160, which is not longer any functional cough. So we make patients aware of this, that if they get a chest infection or something like that, just cold, they get weaker, even weaker, and it's important to use MIE device maybe more in those periods. And these values of 160, 180 liters per minute are often used in publications and guidelines recommendations to start MIE treatment. And this is a flowchart created by Michelle Chatwin, who is a colleague, very, very experienced colleague, worked a long time in a very big environment in London, in Brompton Hospital, with neuromoscopic patients, and had responsibility for their cough therapy. This is one suggestion how to set up, and it's more like a protocol to do it. It's one way to do it, and our way it's not very different from this protocol. But we agree that there is no recommendations that you, very clear evidence-based recommendations that you need absolutely that kind of settings. And we know that if we start MIE therapy, it's indicated, it should be effective for airway clearance, but it should also be tolerated by the patient. So it should be comfortable, like some comfortable, it not needs to be like spa wonderful comfortable, but patient should tolerate it. It should maintain upper airway patency and to be safe. And that's why we have an individualized and patient-centered approach to set up MI therapy. The first thing to consider is, should I just help the patient to cough and allow the patient to be just totally passive? Sometimes it's very relevant, especially during chest infections, acute hospitalizations. The patients not necessarily don't need or don't want to be participate that active to the treatment. But many of these neuromoscopic patients who are in stable, healthy phase, they are living at home, living their lives, they actually want to participate active to the treatment. And that's why my first consideration after making assessments is, okay, do you want to actively participate to the treatment? And also these assessments can give me some directions. If the peak of cough peak flow is below 180 liters per minute, I know the patient needs cough support. The cough is very weak. If the patient is able to make spontaneous inspirations, are not fully dependent on ventilatory support, for instance, is breathing by themselves during the daytime, we know the patient might be able to trigger the insufflation. And in that case, we can use patient's own inspiration plus assist that with the device insufflation. Did we hear a cough sound when they were performing a cough, like a qualitative assessment? Yes, they do it. So we know they managed to perform this glottic closure and opening. And also, is it like more chronic state? The patient is in the outpatient clinic, or we have a home visit, or is it this an acute state with hospitalization and infection? Patients need more support in acute conditions. So when we have mapped these things, our goal often is to get patient and device to work together. And here I use an example from dance, tango dance. And why tango? It's because in tango you have two participants in the dance, and you have both leader and you have the follower. And these parts are changing all the time. So if we would like to use this in MIE therapy, I could say that, okay, the patient use their inspiration to trigger the insufflation from the device, and the device is following, giving sufficient volume. then the device is taking the following lead role and changing to exsufflation, and patient needs to follow that and try to perform this glottic closure and opening if possible. And then the patient decides again the time of how long the pause will be before the patient starts a next insufflation. So this is a very beautiful picture of how we can get both the MIE user and the device work perfectly together. But we also need to keep in mind that we are all new beginners at the first, both patients and us as therapists. So we must allow us to be and have the time to really get masters also in this field. So usually when I have a patient in the first meeting, we just inform them verbally what's happening. We say it might feel a little bit unfamiliar. You will get an insufflation, you will get positive pressure. It will switch to the negative pressure and suck the air from your lungs. But we never say it's uncomfortable. We let the patient feel the flow with the hand, cheek, hair, and get a picture what the MIE device is doing. And then we often use first manual mode, just give some insufflations, especially if the patient is not familiar with non-invasive ventilation. So they will get those positive pressures a few times and then combine with the negative pressures. And here you see this this woman is using both first mouthpiece and then mask, and it's because she has no experience from the mask from the first time and felt that that was a little bit stretched. So mouthpiece can be an alternative, even we find out that in long-term settings the patients are using often masks. But in some cases, the mouthpiece can be an alternative. The manufacturers are delivering several sizes and types of masks, and basically you can use whatever mask that fits the face, but it needs to be tight mask without leakage. And we aim to avoid leaks, but it's not catastrophic if there is a leak. And some patients actually use their facial expressions during the therapy to just create a leak. And that's how they can control a little bit the volumes they get in. But the mask should be comfortable. And if we have patients with artificial airway, tracheostomy, or endotracheal tube, we just choose the connectors that fits and can be cleaned or just changed, thrown away. And it's much easier to set up the treatment with the invasive airway because it's more like plug and play. You don't go through the upper airways that might need some familiarization. And when we are starting with mask, just the one little thing that can be very big thing if it's not considered, and it's that when we try to avoid the leaks, we often push the mask quite heavily to the face, and it could be also better way to do it with the squeezing. But if we press the mask very hard, you can just do it where you are now. You can just take a deep breath and make a sound of ah, and then you just push your jaw inwards, ah, and you will feel that, okay, I'm actually making an obstruction to my upper airways by pushing the jaw too hard inwards. Some patients will also have more beneficial positions, like in side lying position, if the jaw is creating easily obstructions. So just be aware of that. So the device, like it says, mechanically delivers an insufflation that insufflate the lungs, which is created by positive pressure, and then it's switching to the negative pressure and exsufflate the lungs and hopefully also remove the mucus from the central airways. And these cycles are repeated in, out, in, out. We see that the patients who live in institutions, they often have very strict protocols for the caregivers to perform that like 5 or 6 times, and then having a pause, removing the secretions, and then repeating maybe 5 or 6 times. Patients who are cognitive, strong, and have their opinions, they often are experts in this treatment, and after 25 years of using this, we see that many patients use that maybe 11, 12, 15 times cycles after each other, and sometimes just 2, 3 if the secretions comes up more easily. So when we choose settings, there are quite many options to choose from the mode, or if we use it in manual mode or automatic mode, and which pressures to set, which rise time, which kind of time setters, and so on. And about the modes, automatic or manual, it's described some couple times in literature. This is a study by Michelle Chatwin, the same one who described the protocol to set up. They described that they had 181 patients in their clinic at that time, and 96% of patients used automatic modes at home. Only 4% use it manual mode. Another study is published recently by another a UK group from London, Nera Shah, which is another hospital, and they had 360 patients in their registry, and they used automatic modes in 56% of patients and manual mode in 44 patients, which was quite surprising for also for us in Norway, because we maybe are more in the numbers of Michelle Chatwin. But again, it just gives us an indication that we can do this in many ways, and sometimes there is a cultural preferences, also traditions, why we make the choices we do. But there is some settings when we set up MIE in auto mode we need to consider, and then there is also settings that it's not that important necessary to choose at least at once, but in introduction we can try to keep it more simple. So if you remember the phases of cough, so we had inspiratory, we have this compressive phase and expiratory phase. We try to mimic these phases with our MIE setting. And aim with the insufflation is the same as with the deep inspiration in a normal cough. It's to give a sufficient volume for the patient to cough out. Glottic closure cannot be done with the device, but during the glottic closure you get this pressure buildup, and if the patient is spontaneously coughing together with the device, we get the same effect. The expiration phase from the normal cough is now done by exsufflation on the device, and the main aim is to increase the airflow, which can remove the airway secretions. And the necessary MIE settings for insufflation I have written down here. It's to make a choice if the patient will trigger, which kind of pressure we start, and which kind of pressure we titrate the device to have a treatment setting. We have to consider rise time and how long time we want to continue the insufflation. And in exsufflation, it's less settings, it's only pressure and time. And when we have this patient who have never used this earlier, of course, is it acute setting? We maybe need to go more rapidly to the treatment settings. But if we have a neuromuscular patient who should use this over a long time, we should start more mild and to introduce the treatment. And we often start with very low settings, both for insufflation and exsufflation, maybe just 15 centimeters of water. for the first time, and then we increase it accordingly to the response. Rise time, we start, we use often high rise times or like rapid rise times when we have no bulbar patients, and we use slow rise times when it's bulbar patients. Time to set up, it's often you need a little bit more time for insufflation than just regular inspiration in breathing. So inspirations often are longer, and then the expiration is maybe shorter, like and then we just started to change the settings and increase them. And the clinical reasoning here is during insufflation to try to get a good rise and fall in chest and abdomen. We ask the patients, okay, do you feel that you get the deep breath in? And these patients with neuromuscular disorders often really find it really lovely to get this deep thoracic expansion and get a deep inspiration. And we can also observe the tidal volumes on the device. During the exsufflation, we often hear, does it sound more effective now? Do we get the secretions up? How the patient feels? Yes, I feel my cough is stronger. Okay, we are on the right way. And then we can observe the cough peak flow values on the device. Triggering can give a better synchronizing between the patient and device, and it basically means that the patient creates a flow with their own inspiration, with which device detects as a flow change and starts an insufflation. And when the patient triggers every insufflation, we don't set any pause time, but the patient is in charge how long time they want to keep between the cough cycles. If you experience that the patient doesn't trigger well, okay, they might not have strength to that. There are devices where you can change the sensitivity of the triggering to easier, to just choose the baby settings for even the adults and see if it helps. If it doesn't, it might might have too long exsufflation time. So you can also try to just shorten the exsufflation time and see how the patient reacts. Is it easier to trigger now? But often patients prefers this setting to be able to trigger. And if you have patient with problems with mucus plugs, we should turn it off, or at least maybe have one program without triggering. So if there is a mucus plug, the patient cannot create that flow and trigger the device, and we need to start it. Another point why patients should have an active inspiration in the start of insufflation, it's because of the diaphragm, and the only opening muscle in the upper airways, postocricoarytenoid muscle, they have a phasic relationship. So when the diaphragm activates, the only opening muscle in the larynx opens and creates better conditions for upper airways to get the air in. Insufflation rise time, or it also can be called insufflation flow in some devices. It's time the device used to achieve the set pressure. So here it's 3 different insufflation rise times or insufflation flows. The black one is very quick rise time. It's also called high flow. And the yellow one is low flow or very slow rise time. And so this device, which is actually from Philips E70, it's using almost 1 second in low flow to achieve the pressure. There are devices also where you can choose even longer rise time than this. This is a study from Brazil. It's they used this old cough assist Andersen device 3200 and used in manual mode. And they had a hypothesis. They wanted to examine it. Here they had a focus in flow bias. So if the expiratory flow was bigger than inspiratory flow, it will move the mucus more. And they compared the standard maneuver where the insufflation was started very quickly, and then this specialized maneuver where they used manual mode and switched very carefully to the insufflation. And you see from the flow curve, which is the black curve here, that the flow is much lower and the pressure is achieved over time compared to the standard maneuver. And they saw that this kind of maneuver creates more expiratory flow bias that can be more effective to move secretions in lung model. And this was a bench study. It didn't include patients, but a test lung. When we are changing the rise time, we will affect the volumes. So the rapid rise times will give more volumes with the same time setting compared to long rise time with the same time settings. So if you want to use longer rise times, you see that, okay, I don't have a sufficient volume, which was the main aim in insufflation delivery. We can just increase the time and still deliver the insufflation volume that we want, but the treatment will be more mild for the patient. We start with time settings to just initiate treatment. And if the patient has a ventilator in use, we usually see, okay, what kind of inspiratory time they have with that, and then we just increase a half a second. With patients without ventilator, we often start with 1.5 to 2.5 seconds in adults, and exsufflation is often shorter. And we use patient triggering. If the patient is not able to trigger, we choose a pause with 1 second or up to 2 seconds. And these are just to start the titration, and then we will increase this during the therapy session. And we often instruct patients to breathe in and out a couple of times, and then breathe in and cough. And then we increase the pressures gradually. Also ask the patients how they experience it and ask them to give us feedback. And we often end up with asymmetric treatment pressures, which means that the insufflation pressures are lower than exsufflation pressures. And when we have come up to the treatment pressures that are acceptable for the patients and we consider them effective, we go back to the time settings and ask the patients, okay, now you will just feel the insufflation phase. Is it too long? Is it too short? Or do you think it's okay? And then we make the adjustments accordingly to the feedback. And same with exsufflation and potentially with pause if they are not triggering. And when the patients are doing this, we try to also observe the chest wall movement like we do now here. Yes, we get a good rise and then we get a fall. In this next example, we have a high spinal cord injury patient where the aim of the therapy is both cough up secretions, but also to maintain thorax mobility over time and not to get the stiff thorax. So here we use much longer rise times to achieve a really good stretch in the chest. Okay, how long exsufflation then? Well, if we only look at cough peak flow, it needs to be really, really short, like 100 milliseconds, because it happens so fast. But clinically, we don't never ever use these short exsufflation times, because there is something that is time dependent, which is not measured by cough peak flow. There is two outcomes introduced by a French colleague, Mathieu Lacombe from Paris, who introduced effective cough volume, which was the volume patient expired over 180 liters per minute of cough peak flow. Another outcome measure they introduced us was the effective cough time, which is the time during exsufflation where the cough peak flow exceeds about 180 liters per minute. So these are not that easy to measure. They are not indicated in the MRE devices that are we have today, but hopefully also this kind of outcome measures could be included in the future. We also need to consider how the patient prefers or is able to cough. So like if you think about yourself and coughing, is it like or like long cough? These curves are from one of my cohort I have studied. It was the first example, it was healthy control, where the expiratory flow, it's lasting almost 2 seconds we have set up here. In next example, we have a spinal ALS patient. You see the flow is not that high generated with MIE, but it's maintained these 2 seconds. In the two last examples, we have bulbar patients who generates a peak, but the flow is quite low. And in the last example, it's almost not existing after 1 second. And these patients need different exsufflation times. And these things we can also detect with simple auscultation of the throat and to hear if we hear the airflow during the exsufflation. And John Bach, he's American doctor who has helped us a lot from 2001 to set up MRE devices and guide us how to perform the treatment. He was very clear that we need high pressures. And the last years, he has advocated us to use even higher pressures. And we really believed in John Bach in 2001 and the following years. And that's why we saw that it was really hard to success with some of the patients because they didn't tolerate these high pressures. The London group with Michelle Chatwin, they were more conservative, they were more careful with the delivered pressures. And in this early publication from that group, they used the mean pressures only 15 centimeters of water. But when they compared different cough augmentation techniques for both children and adults with neuromuscular disorders, they saw that mechanically insufflated exsufflated assisted cough was most beneficial to increase cough peak flow. This is one of the recent publications from another London group with Nera Shah, who compared high pressures to low pressures. 60 versus 30 centimeters of water, and they included both Duchenne patients, ALS patients, and they saw that these high pressures, they don't necessarily increase cough peak flow in all patient groups, and they don't lead to lung recruitment or breathlessness in patients, but they are less tolerated and generated more upper airway closure, affecting expiratory volumes. In our studies, I will come back to this next week. We have examined ALS patients. We have visualized their upper airways during the MIE therapy, and we have seen that positive pressures cause laryngeal adduction. And this happens either initially in inspiration or during the insufflation time. And when we change to the exsufflation, it's quite narrow, but it's not strange. When we don't manage to deliver any insufflation volumes, we create a vacuum, and it's very difficult to exsufflate anything from the patients. So these upper airway assessments have been increased in interest in the latest years, and both visualizing and using the waveforms of the coughing with MIE can give us valuable information how it ends. And based on our visualization, we have had more attention to fine-tune the insufflation settings and have more careful pressures, rather longer insufflation times, increased rise times, or use these low insufflation flows like it's called in some devices. And this practice also aligns with the London cohort from Michelle Chatwin, who has documented to use this kind of asymmetric treatment pressure approach in all their patient groups. This is a study from my good friend and colleague here in Norway, Britt Hove, who studied first to just map out how the patients, children with MIE therapy at home, which kind of settings they have. And this is a figure where we have plot in all the clinically used settings from the patients that were reported, both for the times for insufflation and exsufflation, and pressures for insufflation and exsufflation. And we see a clear trend that when children is getting older, the settings is also increased. So I would say yes to both high and low pressures. And some patients, they love these high pressures. Some patients don't tolerate them at all. A good option is to combine lower insufflation pressures with higher exsufflation pressures. And just remember, the aim with the insufflation is to achieve a sufficient inspiratory volume. In critically ill patients with artificial airways, endotracheal tubes, and tracheostomy tubes, it's more protocolized settings that is used. This is a literature study from UK, a group of Emma Swingwood. They mapped out which kind of settings has been described in the literature with critically ill patients. And this is a focus group study, a qualitative study from Netherlands, where healthcare professionals working on the intensive care units were interviewed, and they tell how they are using. It's also in line with the Emma Swingwood's results. We know from some bench studies that artificial airways creates more resistance for these pressures and doesn't necessarily create the same expected wished expiratory flows. So these patients might need higher pressures. And it's much easier to set up tracheostomized patients. It's more like plug and play. And it's because we bypass the upper respiratory tract. What is very important with tracheostomized patients is that we might use much less airway suctioning when we use MIE to clear the airways, but it's really important to go through the cannula and just below after we have end up the treatment to clear the cannula. And we do often that after a few cycles of MIE, we get secretions up and we just go with the suction catheter through the cannula and just below, but no deep suctioning is not necessarily needed. So we need to also consider, okay, do we need any other additional settings? And which has been suggested, and many of the devices provides, is the oscillations. There are no big proof evidence that these can make the treatment more efficient. And it's basically because the outcome measures used are the cough peak flows, and it hasn't increased that. So in our visualization of the upper ways, we see that if the option is just closure, it with oscillations, it can be openings and closures in the upper airways, and it can be beneficial for that individual patient. And we also know that these oscillations might create more turbulence that might be more effective for the thicker secretions, at least in some phases of the disease, maybe when they have acute respiratory infections. There are also devices that can deliver both pre and post insufflations, and I have here now 3 examples. The first one is just to give regular MIE cycles first and then add an insufflation to increase the volumes after the treatment. Another example is to give first 3 insufflations with a little bit lower pressures, then 5 cycles with MIE therapy, and then again 3 cycles with lower pressures. And third example is just 10 insufflations and then 3 coughs end up with 1 insufflation. We use this kind of approach when we are considering, okay, where are we in airway clearance therapy? Are we to just evacuate the mucus? Then the MIE cycles are most important. Or are we finished airway clearance and now we have a focus more in lung volume recruitment and we wish to increase the volumes? Okay, I have now a user perspective. This is Marita. She has SMA type 2. I'm not sure if you hear the sound, but I have texted because it's in Norwegian. So Marita has 3 programs, and the first one is, like she said, it's an everyday program. It's plus 32 and minus 40, 2 seconds of insufflation, 1.5 for exsufflation time. And then when she needs a little bit more power, we have just increased the settings a little bit more, but also both for the pressure and time. And the third program she feels it's more efficient during when she gets thicker secretions. It's the one which has added also oscillations. And there is a development of devices, and we have seen many devices already during the years. And new technology, they create new settings, and they gives us therapists also new ways to think. So where we are in 5 or 10 years, it's very excited to see that. So to summarize, I will first consider, do my patient can participate active? We start with the necessary settings, keep it simple. There are many ways to roam to give this sufficient volumes and good expiratory flows. And then if needed, we can adjust some settings to give more comfort or and we use this kind of individualized patient-centered approach. We include the patient in the decision making, and it takes always to the tango, and even 3 is user device and therapists are included. So I want to thank you for your attention. And next Tuesday we have another session. It's more case studies with ALS. So if you have any questions, I'm happy to answer.
Wonderful. Thank you so much, Dr. Andersen. I would like to, as you're thinking about your questions, I'm going to remind everybody that you're muted, and that is just so we can maintain quality of the video and audio. But please type your questions into the Q&A box in the bottom of your Zoom control panel. and then we will review them. This is accredited by the AARC, and so in order to receive credit for that program, or for this program, excuse me, you'll need to complete the feedback form that you will receive via email tomorrow. Otherwise, you can scan this QR code and complete the feedback form. And then within a week, we will send you a certificate of attendance. And we've had several questions about the protocols and some of the details that Dr. Andersen has shared. So we will send out a summary of her presentation with the certificate. And remember that we do have another session with Dr. Andersen next week. So please scan this QR code to register for that session on September 23rd, and other CEU programs that you may like to participate in. So with that, I'm going to stop sharing and we're going to answer questions. Okay.
Yes, I see that there is some questions in the chat. So good morning, yes, and good afternoon from here. I will share the protocols, yes, and there is one question about to describe how to get a cough big flow from a patient with tracheostomy if they don't have no spontaneous cough. Well, it's if the patient it's an inpatient, like they have a ventilator, we sometimes they just cough, and that creates a flow to the ventilator screen. So in that case, we are in the room and that happens. We often freeze the screen and then we measure that. Uh, but if you have a patient tracheostomy, there is no spontaneous cough, you hear the secretions, we are more pragmatic and think, okay, here we need to help instead of just using tracheal suctioning. I don't know if that answers your question, but if there is no flow, it's no flow. We have to create that. In pediatric patient, yes, we often use the same kind of protocol or individualized approach. And in our clinical practice, we see that these pediatric patients often need the same pressure settings like adults. And we have this colleague, Britt Hoof, she has PhD in pediatric MIE. Maybe she can also share her experiences in the future. Yes. Do you see any other? Is there any evidence for using MIE to prevent post-extubation failure in patients with weakness? Yes, there is some. But it's less in intensive care units. There is Miguel Concalves, for instance. They have published, it was a randomized control study excluding neuromuscular patients, and they show that it's more efficient weaning. And also Emma Swingwood from UK, she's doing clinical studies with the ICU patients. Yes. Can you have the same time for insufflation and exsufflation? In the examples, I noticed the insufflation times were always longer than exsufflation. Yes, of course, you can use whatever you want and whatever your patients want. And often these study protocols that we have, if you read the method section in the studies, they have actually had the same settings for insufflation and exsufflation. So, but in clinical practice, we see that when we use lower insufflation pressures, we often have a little bit longer insufflation times. So it's maybe therefore. Would you recommend cough up or down for tracheostomy? Well, we cough up them during the MIE therapy, and it's just to try to have the treatment below the cough. However, we have a protocol. I know I might be arrested to tell that in the United States, but it's we use the devices where you don't have insufflation time restrictions. And this protocol we have been using more than 20 years. It's to use quite low insufflation pressures, like 20 centimeters of water in manual mode. And we start to create an insufflation. It goes quite rapidly, just a couple seconds, and then we deflate the cuff and we continue the insufflation. So the pressure is built up in the thorax, and then the air is leaking outside of the cannula, and often taking the saliva and mucus that are above the cuff up to the mouth. And we haven't had any uh, any injuries. We have been using that in whole country, but most of the new devices, they have restriction for the insufflation time, so it's not that easy to perform with all the devices. But I know our tracheostomized patients are basically just cuffed because they are ALS patients with bulbar symptoms. Otherwise, we manage very well with non-invasive treatment. Are you ending? Oh, for vital capacity and MIP and MEP, which values do you use to determine if the MI is indicated? Well, if the vital capacity is less than 1.5 liters, they often need cough assist. MIP and MEP, it's more to indicate, okay, is it more like inspiratory or expiratory weakness? Where do we need to assist more? If the both values are poor, like last week, I was testing one of our Duchenne patients, and a little patient, MIP was like 2 and MEP was like 1. Why do we assess? It's nothing. It's not functional anymore, and this patient just needs support for both, for inspiration and expiration. Are you ending on inspiratory phase to leave the patient recruited? Yes, we do that often. And it's a good way to do, instead for just exsufflate them, and then the patient is using a long time to come to the certain FRC. Okay, a long question. Please note that MI is not just for airway clearance. Yes, I totally agree. And so we have also this aim to keep to prevent the stiffness of the thorax. The studies haven't been so optimistic. There is one, where is that from? Is it from a French study? Who showed that the vital capacity of these neuromuscular patients could actually increase after the start of MIE. It was a retrospective data, and it also indicates that it does something for the stiffness of the thorax. But most lung volume recruitment studies haven't been that optimistic, and it's maybe because those have included patients too early. But when to start, it's difficult, and it's not always the aim to just prevent the stiffness of thorax or clear the airways, but it also can be to teach the patients to use it, because we know they have diagnosis, they need it later. Is it effective using lower 15 pressures in pediatric population? We use pressures 35 to 40 for our pediatric. Well, we often ask the comfort, and we don't want to lose the patients in the start. So if you have like acute infections, it might be of course, prioritize to get the secretions up. But if you have a patient who has a neuromuscular disorders, ALS, and we know they will need a long-term therapy, we are also aware to not scare the patients with the first meeting, to try to, maybe they go home with the settings of 15, 20, 25 centimeters of water, and we don't expect it to be very effective, but they can change the next program when they are comfortable with the program 1, and then further to program 3. But of course, some patients have these everyday settings, and then they have these higher settings also if they get infections.
Good. Thank you, Dr. Andersen. We have a couple more from the Q&A box. Let's see. So I don't know if you can open that. The first one was about.
Yes.
Okay.
For tracheostomy patients, is there benefit for having the cough up was done. Well, the cough up is beneficial to have maybe more effective treatment below the cough and avoid the leakages. So our patients basically often have this coughed cannulas. Okay, you mentioned leak is not important. We find first it will feel much stronger when the flow compensates with higher leak, as that's the one that words accurately. Yes. So yes, so if there is a leak, the volumes will be way too high. We have not delivered that much volumes to the patients, but we were very, very aware that we should not create any leaks in the start. But we saw that the patients were actually using this self-leaking adjustment to also control a little bit the volumes they needed in. So we haven't, we think they are the experts in this treatment and we are just assisting them on the way. And decide mouthpiece versus mask. Well, if they can do both, we recommend mask. But of course, if patients have non-invasive ventilation also many, many hours a day, it might have more skin issues. And so we are not very strict and say you have to do it on this way. We are always a little bit curious how the patients find out it's more efficient for them. Okay, one more. How do you determine what settings numbers to start on for oscillation, or is it patient comfort? Well, here, okay, so if you have a low amplitude and very high frequency, it's quite mild. If you have higher amplitude and you have low frequency, it's more powerful. I ask the patients, okay, what do you prefer? And often the patients prefer high amplitudes and low frequencies. I also, in some ALS patients who don't manage to make the glottic closure and opening, I use these oscillations during exsufflation with high amplitude, flow frequency to create that kind of turbulence that glottic closure and opening can create. So we don't have much evidence, but our user perspective says, okay, high amplitudes, flow frequencies.
One more.
Yes, does oscillation affect cough flow? Well, the studies have shown that it doesn't affect the cough peak flow, but the cough peak flow, it's just one peak in very, very short time. If we would have a study that also included this effective cough volume and effective cough time, we could get more information. Is it more beneficial to create a flow during the whole exsufflation phase? But we don't have that evidence yet. So I definitely think it makes something with the flow out, but we haven't numbers on that.
Good. All right. I know we're over time. Does anyone have last questions before we conclude? Okay. Well, thank you everybody for joining. Dr. Andersen, thank you for sharing your insights and that great information. As I said before, we will send out a summary of her presentation with the certificates. So please complete your evaluation forms. You will get an email tomorrow from Zoom if you didn't click on the link or the QR code earlier. All right. And with that, we'll conclude. Thank you so much. Have a good rest of your day.
Thank you, and thank you for all the thank yous. It was very nice to get those. Okay. Have a nice day and see you next week.